That's nice.
It's still a lot of photos. It's actually nicer as a Kindle.
Yeah, it's
You can reuse the photos and
maybe
put them on
like-
lectures.
Yeah.
Good morning, everyone. Thank you for coming to this session of Grand Rounds today. Today I have the pleasure of introducing Dr. Jeffrey Radcliffe. Dr. Radcliffe is the Assistant Program Director of Neurology Residency, as well as Director of Movement Disorder Fellowship at Thomas Jefferson University. He completed his BA in Psychology at the Haverford College and Medical Doctorate at the University of Rochester School of Medicine and Dentistry. He completed his internship at Neurology Residency at the University of Virginia, and he went on to do his fellowship in movement disorders at Bethesda. He's a part of multiple clinical trials in management of Parkinson's and also has actively contributed to a neurology podcast series. So it is a pleasure to have Dr. Radcliffe today. He'll be talking to us on spiraling out of control, a writing task, the evaluation of movement disorders. Thank you.
Thank you. All right. Okay. So no disclosures, but what we're going to talk about today is kind of looking at the history a little bit of using handwriting tasks in our evaluation of neurologic disease and neurologic disorders, and then kind of talk a little bit about the methodology. How do we use these tasks at the bedside in the clinic to kind of help us refine our differential diagnosis? And even beyond just looking at the examination technique, what do you do with the actual spirals that have been drawn? So are there characteristics of spirals that are drawn by patients with different movement disorders that give us some diagnostic clues or clarity? And then taking it on from there, I want to talk a little bit about what can we do with this fairly well-trained, fairly easy to do motor task to learn a little bit about the physiology of movement disorders. And so, in looking at the history, it's always a good idea to do a movement disorders talk and talk about James Parkinson. And so what Dr. Parkinson described in his original essay on the shaking palsy was that patients really might not even notice the subtlety of their disease except with handwriting. That may be one of the first manifestations that they can identify their disease. And really what this goes to point out is that, handwriting and a motor task is a pretty refined and dexterity-heavy motor task. But when you start to have movement disorders, it may be one of those kind of first steps to go. And that goes back even as far as Parkinson himself. And even in looking at Charcot's lectures, Charcot was known to take a magnifying glass and look at the handwriting of his Parkinson's patients and kind of look at some of the asymmetries in the pressure that was being exerted with the pen, looking at some of the tremor. So again, it's hard to find good examples in the literature of how long we've been watching patients write or using a spiral task, but we know at least kind of looking at some of the forefathers of modern neurology that they've been using handwriting, or at least the written product of their patients, to kind of help evaluate the diseases that those patients had. Does anyone recognize who this gentleman is? So this is Archimedes. And so the reason we're talking about Archimedes is this particular figure here. So Archimedes is credited back when he wrote a book piece called On Spirals, and kind of was discovering that this is a spiral which its radius increases at a constant rate proportional to the angle as you rotate around. So for every degree you go through, the radius increases by the same amount each time. It was actually one of his predecessors who first described it, but Archimedes gets the credit, and so we call it an Archimedean spiral or an Archimedes spiral to this day. And these spirals are pretty ubiquitous in terms of our rating scales, and they've been fairly well validated across the rating scales within a lot of different movement disorders. Most commonly, you're going to see it in different tremulous movement disorders. So pretty much every tremor rating scale has some component as part of that rating scale where they ask the neurologist or the rater to watch the patient draw a spiral. And we'll talk a little bit about the methodology, but spirals, especially in tremor, are kind of hand in hand with part of the evaluation of those patients. In dystonia, our most common rating scale in dystonia is the Burke-Von-Marsden rating scale. And again, in addition to other components of the dystonia exam, there's a component on that we'll ask them to watch the patient write and to watch them draw spirals. I put Parkinson's disease up here. Certainly there are characteristics of handwriting and spirals in Parkinsonian patients, but as many of you probably know, handwriting and spiral drawing are not part of the 55 Parkinson's disease rating scale. So that's one example where our kind of classic rating scale for this disease doesn't include handwriting. And I put MS down there not because it's part of most of our standard rating scales for MS, but there have been researchers who have taken some of the tremor subscales for spirals and looked at those spiral scores in multiple sclerosis patients and using that as a corollary for disease severity. One of the important things, if you look at some of the tremor rating scales, are that there are some scales that have a spiral subscore. So it's a 0 to 10 rating of how severely affected is this spiral. And that rating correlates pretty highly on the order of kind of an R value of 0.7 or so with the overall tremor severity. So we know that this kind of quick and dirty test gives you a pretty good overall assessment of how severe is this patient's tremor. The other thing that they found that it correlates pretty highly with is the impairment on activities of daily living at home. So again, the severity and the impairment in spiral drawing can give you a decent assessment of how affected from a functional standpoint is the patient you're evaluating. And so why do we even use these writing tasks? I talked about how Parkinson and Charcot kind of recognize the importance of these tasks. And so these handwriting samples are from a more recent sort of giant in our field of movement disorders, David Marsden. And so what Dr. Marsden recognized was that writing is what he termed a motor plan. And a motor plan is really a sequence of motor tasks that are strung together to perform an outcome. And that motor plan takes information from, we think about our corticospinal tract as kind of our main primary motor pathway, but really what these motor plans are is integrating that information from the basal ganglia and the cerebellum. So the motor plan is very much a function of basal ganglia and cerebellar functioning. And you can kind of localize dysfunction to some of these motor tasks to those parts of the brain, and these extrapyramidal or auxiliary motor functioning structures. What Dr. Marsden is demonstrating on this slide, so this sample of his handwriting here is his holding the pen as we normally would between our fingers, resting our hand on the desk and writing Parkinson's Disease Clinic at King's College Hospital. This next example is Dr. Marsden holding the pen kind of with a fist and kind of using his elbow as a fulcrum. And this last sample is him holding the pen out in front of him almost like a wand and writing on a whiteboard using more of the proximal shoulder muscles to form the letters. And what the point that he's trying to show is that even though he's using kind of finger flexors, wrist extensors versus kind of biceps, triceps, elbow flexors, extensors versus muscles of the proximal arm and shoulder girdle, the handwriting looks pretty darn similar regardless of the muscles involved. And so what he's trying to point out is that this is not just corticospinal tracts going to certain myotomes and muscle groups. This is integrated motor information that holds true regardless of which muscle groups you're using. So that's kind of his example of how can we localize into this writing task to kind of these extrapyramidal motor structures, so to speak. So how do we do this? How do we have patients write in the office? And there's some consensus and there's some diverging opinion that we'll talk about. The kind of consensus is you really want, as best you can, to have the patient squared up to the desk, sitting as upright as possible. Certainly looking at some of our Parkinson's patients or our dystonic patients, depending on their severity, sitting upright may be more of a challenge in some patients than others. But try to get them squared to the page as best you can. And then the other thing where there's some divergence is, do we have them write normally, as we normally would, with the hand kind of resting on the desk as if any of us were taking notes? Or do you have them hold the elbow and forearm up off the desk? It's a little hard to see, but really the only thing touching the paper or touching the desk of this patient's writing hand is the tip of the writing implement itself. And that, some people would argue, can kind of bring out, kind of reduce some of the stabilization that might suppress some of the involuntary movements that come out with handwriting. And people have studied this. So what I'm showing you here is different spirals from the same essential tremor patient. But the way that they have differed is the instructions and the methodology with which they were created. So there's a couple of different differences here. So one, they looked at, how do you instruct the patient? Do you tell them, write the spiral quickly? Do you write it slowly and carefully? Do you write it softly? Do you write it, quote unquote, normally? And what they found is in patients with essential tremor and dystonic tremor, whether you tell them to write it, quote, normally, quickly, or carefully, doesn't really matter. The spiral severity scores is pretty similar across raters. If you have them draw it, if you instruct them to draw the spiral softly, they actually found that those spirals were rated more severely affected. So there may be some, you may increase your sensitivity a little bit by telling the patient to softly draw this spiral. And again, maybe you're taking away some of those bracing and tremor suppressing maneuvers patients might do by really kind of pushing the pen down hard into the paper. What we're looking at here are that methodology in terms of how do you write the spiral. Do you support the arm on the desk, or do you not support the arm on the desk? And what these columns are, you can see underneath here, there's an example spiral over which the patient is tracing. And then here's that example spiral inside which the patient is drawing within the lines. And then these are examples of free-handed spirals. And so they wanted to say, well, does that make a difference? Should you give them kind of a spiral example and have them trace around it, or should you just say, draw a spiral for me? And what they found was that looking just at supported versus unsupported spirals tend to be rated worse than supported spirals. So you do probably bring out a little more of those involuntary movements if you lift the arm and the wrist and everything up off the page with the exception of the tip of the writing implement. As opposed to looking kind of in these variables, the online, within line, or the free-handed, they're pretty similar across. But the online does tend to be rated worse than the within line. So these ones tend to be rated worse than within. And they tend to be rated worse than the free-handed ones. However, if you want to do a trial looking at spirals, the inter-rater reliability is really the best with these free-handed unsupported spirals. So, if you have the time, kind of put them through different modalities. You're probably, maybe going to pick some things up. If you're actually studying spirals themselves, kind of the reliability and validity is probably best with these free-handed, unsupported spirals. So that's a little bit about the methodology. When we talk about what do we do when we're examining these patients, and so kind of this trust the process. Watch the process of writing the spiral. The product of looking at the spiral itself is not enough. You should be in the room and examining the patient while they're going through this task. And really what you want to pay attention to, look at the posture of the hands. Are the arms, are the hands, either the one writing or the ones not writing, starting to take on or go into any abnormal postures? Is the grip dynamic? Is the grip kind of changing? Is it tightening, or is it adjusting as they go through the writing technique? Are there other involuntary movements, little jerks, or golfers can call, golfers have this term called the yips, where maybe they have some trouble kind of approximating the pen to the page because there's kind of these jerky movements that might pull it away. We'll look at some of that. And again, overflow movements. Look at the part of the body that's not writing. Look at the feet. Look at the other arm. Look at the neck. Do you see dystonia or other tremor that's coming out? Because some overflow movements or some abnormal posturing may give you a clue that maybe you're looking at a dystonic tremor over a regular run-of-the-mill essential tremor. So here's So this is a patient with DYT6 that I followed in fellowship, and you can see abnormal wrist extension as she's writing. You can see kind of this grip is certainly not normal. Kind of fisting the pen a little bit. If you look back at her other hand over here, you can see that non-writing hand is kind of clawing up. So you can look and see some of the overflow dystonia in the other hand. And now have her right left-handed. Now you really see that kind of prominent wrist lateral deviation. You see a little bit of extension. She's pushing down a fair amount to kind of stabilize with her trunk as best she can. A little bit more of that abnormal wrist posturing as she's going through this spiral drawing task. And so these are some features of, I mean, this is a patient with generalized dystonia, just looking at her writing itself, but you can already start to see kind of some of those features that we want to look at. And here's an example of some of those writing yips I was talking about. So I want you to watch as he tries to approximate the pen to the page. You can see there's kind of this involuntary movement, kind of pulling the pen up off the page, kind of this, almost this proximal arm dystonic movement, and jerks the pen up. And even when he starts writing, I didn't show it, but he starts to have some writing tremor as well. But that was kind of the exemplar I wanted to show from him. Here's another example. So people have talked about this phenomenon of primary writing tremor. Is it a tremor disorder, or is it a dystonic disorder? And so in addition to looking at the grip that that the patient adopts normally, you can also alter their grip. Give them an altered way to hold the pen or writing implement and see, does the movement disorder change if you start to utilize different muscle groups. So you can see as he goes to write, you can see it best watching the paper. You can see that tremor starts to come out as he starts to write. And kind of as he's going, gets some intermittent tremor. He does pretty well once he starts writing. But then we give him a different grip, he doesn't really have a writing tremor anymore. So a lot of people have used this phenomenon as an example to say, maybe writing tremor is more of a dystonic phenomenon, kind of a different flavor of writer's cramp, where by recruiting different muscle groups, kind of using the non-dystonic muscles, we start to see that people can perform the task normally. And so sometimes we'll see, let's give patients a different shaped pen. There's kind of the horseshoe pens that kind of may adapt the grip as well. So sometimes you can take advantage of that therapeutically as well. This is touching on some of those mirror movements. You can see in the photo on the left, after she's kind of written the first line, she starts to write the second line. Everything looks okay, but then as she kind of gets into that second line, you start to see that non-writing hand with some dystonic extension of the second and third digits there. So kind of looking right in that second panel there. And going back to our patient with this primary writing tremor, which we suspect is a dystonia. So those overflow movements make you think dystonia. When we watch him write, you can see that writing tremor come out in the non-writing hand. So again, kind of another clue that maybe this is a dystonic phenomenon, where whenever his brain is like, all right, we need to write, there's some sort of activation of some of those small wrist flexors, wrist extensors, and lateral deviating muscles that starts to bring out some of this writing tremor. So that's a little bit about what do you do when you're examining these patients, right? What do we do with the spirals themselves? So now they've drawn these spirals on the line, within the line, free-handed, we've watched them do it. Are there characteristics of the spiral itself that give you some diagnostic information or some diagnostic data? So I'm going to talk a little bit about what we call the axis of the spiral. I'm going to talk a little bit about the frequency and how can we use writing tasks to calculate the frequency of someone's tremor, and then a phenomenon called tightness as well. So we'll talk about that. So talking about axis. So here's those spirals again that we were looking at from the methodology study. And this is the same patient, but you can see there's certainly some common features of these two spirals. And that common feature is the axis. And so when we talk about the axis, we talk about the angle at which the amplitude of the tremor is greatest. And that's a feature you're going to see in essential tremor, and you're going to see it a little bit in Parkinson's. If they have a little action tremor as part of their Parkinson's, you can see some spiral axis come out. But really, when you see axis, you're thinking about ET. And kind of the best way to think about that, a lot of times we'll talk about it in terms of a clock. So this is a patient drawn with the same hand, kind of roughly a 10 o'clock, 4 o'clock spiral axis, kind of running along this line. You can see that that's where those tremor amplitudes are the biggest. Another interesting feature of spiral axis, so here's Parkinsonian spirals with a little bit of action tremor. But the spiral axis is deviated 90 degrees from one hand to the other. So if their axis in the left hand is kind of running at 10 o'clock, 4 o'clock, the right hand you can see is kind of turned 90 degrees the other way. And so we can kind of see that, we kind of turn it 90 degrees, and now all of a sudden those spiral axes are parallel. So that's another feature to kind of think about what's the normal physiology of a spiral, and you want to look for that. If they're drawing a spiral one hand to the other, you would expect those axes to be deviated. And that's as opposed to, here's an example of a dystonic spiral. So someone with dystonic tremor, you can see that there's not really a dominant axis. There's tremor, there's undulation of the lines, but is there a dominant axis? Probably not. So that's kind of a quick and dirty way maybe you use to kind of differentiate. So if we study it, how good is it? And so Alon Lewis's group up at Yale has done a lot of work on tremor physiology. And so Alon said, well, maybe we can use spiral axis to try and distinguish ET from dystonic tremor. And when you actually look at it, it wasn't great. There's still some dystonic spirals that have some higher axis scores. So what he did was, he said, all right, I'm going to have everyone draw 4 spirals, and the number of spirals that have a clear axis, that's their axis score. So 0 to 4. And if they have an axis score greater than or equal to 1, about 84% of those patients were essential tremor. But there's certainly some bleeding in of the dystonic tremor patients as well, about half. And then you get a little bit more specific, but you sacrifice a little of your sensitivity by moving that axis score up to 2. And that, as you kind of increase the burden and make dominant axis more of a requirement for diagnosis, you are gonna start to miss out on more of your essential tremor patients. But Alon has done studies showing that maybe as much as 30 to 40% of ET patients are misdiagnosed, and the most common misdiagnoses are Parkinson's and dystonic tremor. So if we have some tool that gives us a little bit of a clue, especially if we're looking at therapeutic trials, trying to look at genetic studies to figure out, inheritance of essential tremor, anything we can do to kind of further homogenize those action tremor patients is probably to our advantage. So, show you another video. So here's a good example. This is a patient, pretty severe ET, to the point where she's actually a little unusual. She has some cranial involvement as well with some jaw tremor. But you can see she's got a prominent action tremor on both sides. And so we kind of showed this, and now if we watch her right, now we can start to see, you can see that axis deviated kind of at that 2 o'clock, 8 o'clock sort of direction. And now if we switch it to the left hand, we can already predict that we're probably now going to see that tremor change in axis deviation. So now we're kind of in that 10 o'clock, 4 o'clock sort of orientation. So that's a little bit about axis. When you see some dominant axis, you're thinking about essential tremor, to a lesser degree Parkinson's. What about frequency? So can we use a handwriting task to calculate the frequency of the tremor? So the reason I show this after spiral axis is because once you've had the patient draw a spiral, you can use that spiral axis to help figure out how to calculate the frequency. And what I mean by that is if we look at this spiral, you can see this patient has an axis that's, at this 2 o'clock, 8 o'clock sort of orientation. When they just draw a line along one of the lines on the page, you can certainly see that there's tremor, but the undulations of the tremor are not as prominent. But if you have them draw a line perpendicular to that spiral axis, you're going to see a lot more definition of the amplitude of that tremor. And it's like, okay, so you can see the tremor better. Well, how do we use that to calculate a frequency? And so what you can do is, let's say you have this patient draw a line for 2 seconds, and then you go in and just, quick and dirty, start counting oscillations, and if they have 16 bumps over a 2-second line, you've got an 8 hertz tremor. And so now you can start to explore a little bit about some of the physiology of their tremor. You can kind of do this little quick and dirty method to say, well, I know essential tremor tends to be kind of 8 to 12 hertz. Is this patient kind of in that ballpark where, yeah, I'm pretty sure this is essential tremor? Now maybe you knew that because they had a pretty dominant axis before, but here's another piece of data that you can collect right there in the office. So that's kind of a nice task you can do, but you have to see the axis because you're really going to see that tremor most clearly in that perpendicular line to the axis. So the last feature of the spirals that I want to talk to you about is something we call tightness. And tightness, makes sense. It's how many loops are crammed into the given area that the spiral covers. And I want you to think of tightness as kind of an analog to hypokinesia, or reduced amplitude of movements in Parkinson's. So just as a Parkinson's patient who's going through the UPDRS and they're tapping their fingers and they have trouble maintaining amplitude of those finger taps, the Parkinson's patient's going to have trouble increasing the amplitude of serial loops of the spiral. So they kind of get stuck in this radius and they can't really break out of it. And you can think of that where they get stuck in this amplitude of finger taps and they can't really make them bigger anymore. So when you see these tight spirals that start to loop over and over and over one again, you're thinking more of PD, and then we can kind of look at some of our normal examples, our dystonic example, and again, our essential tremor to a lesser degree, but certainly tightness is not a feature of this ET spiral here. Then what about functional tremor? So we see a lot of patients who are worried about, is this a functional tremor, is there, conversion disorder or psychogenicity or whatever term that we want to use to call them. So can we use spirals to kind of give us a clue about, identifying functional tremor as well? And really the key to think about, just as when you're examining functional patients, regardless of their symptom, you're looking for variability from task to task. Does this really fit what we know about the normal physiology? So we've talked about what's normal physiology of spiral drawing. So now, if we look at this example here, here's the physician's example saying we'll draw one spiral clockwise and draw one spiral counterclockwise. Based on what we know, the spiral should not completely decompensate and fall apart just because you're drawing it in a different direction. So kind of this variability, just by changing one variable in the spiral, kind of gives you a clue. Maybe there's some functional overlay or some embellishment of this spiral here. You can see axis, and you can see a 90-degree deviation in axis in functional tremor. But what again we're showing here, so there's amplitude, and then there's these big jags of kind of this change in amplitude. Where all of a sudden here's this big deviation. Or if we look at this other hand, maybe there's an axis here, but here's a loop, here's a loop, here's a loop, here's a loop, that all of a sudden are kind of not really fitting with the axis. If the axis is changing in the midst of a spiral, not really physiologic based on what we've talked about so far about normal spiral physiology. And then the last thing is kind of, is there variability in the frequency? So they're going along, and then there's kind of this intrusion of kind of this high frequency tremor that comes out, they're going along, maybe this intrusion and then an intrusion here. And you can see that when you're watching them write as well. So I want you to watch this guy, he's going to go around this way. But kind of watch him as he gets to kind of 9 o'clock on the spiral here. And so you can see kind of these intrusions of abnormal frequency kind of interrupting the spiral. And that can be another clue that maybe you're looking at a functional tremor disorder. So just to kind of review, there's kind of some, looking at the product spiral itself, we've got our kind of classic ET spiral with clear axis. We've got our classically tight Parkinson spiral are erratic, irregular dystonic spiral. We'll talk a little bit about dystonia at the end, and kind of our unusual sort of variable functional spirals. So now what can we do to kind of digitize these spirals? So we've been looking at spirals for centuries. We've been looking at handwriting casts, but now we should have the technology to kind of, how can we measure patients while we're writing these spirals in real time? And so we can take something like a graphics tablet, and we can measure not only the variables that we just talked about, but we can now start to look at downward pressure during writing tasks. We can start to do some mathematics and kind of take this spiral that we know the radius gets big at a constant rate, and so if you map out the radius versus the angle, the nice thing about this spiral is it gives us an ideal spiral gives us a nice straight line. And so now that we have that straight line, we can start to do mathematics that I'm not going to get into here because I don't understand half of it, but we can start to do some analysis on that spiral data that we've collected by mapping out these coordinates as we're drawing, and start to learn a little bit about some of the physiology of the spiral itself. And so we can look at frequency, we can look at tightness, we can look at axis, but we can also look at spiral irregularity, we can look at unpredictability. And so here's an example, here's our spiral again, and through kind of analysis we can calculate, well, there's our axis. And so now we can kind of use some power analysis and Fourier transforms of different waves on that unraveled spiral and say, well, at which coordinates is the amplitude of the tremor greatest? Well, those coordinates, what angle do those coordinates map out to? And boom, I can calculate a spiral axis. We can look at other things. We can look at what's called the width variability. So you can see between successive, so at a given angle, so at this 270-degree angle, we can see here's the width between one loop, here's the width between another loop, and then you can imagine this can go on. And you can do this at any angle and start to calculate how wide are these loops, what's the variance between those loop widths, and we can map that out. Are the loops pretty consistent, kind of close to the mean, and they're pretty equidistant from one another as we should expect in an ideal spiral, or are they kind of all over the map? And so we'll talk a little bit about width variability, but I'm just kind of highlighting some of the spiral, what we call spiral indices, that give us a little information about physiology. So a lot of this work has come from Seth Pullman up at Columbia, who I worked with a little bit in fellowship, and he's kind of taken a number of different spiral indices, some of which we've talked about. We talked about axis and tightness. He has other indices that look at irregularity. How often does that spiral tracing draw kind of the line of best fit? How unpredictable is that spiral? And so what Seth did is he took a whole bunch of spirals drawn by Parkinson's patients, tremor patients, dystonia patients, cerebellar patients, gave them to his movement disorder colleagues at Columbia and said, rate these spirals like you would an item on the UPDRS. Rate them 0 to 4. And so he gets all these different raters, and he kind of has these collections of spirals from different diseases, and they have a degree of severity score assessed by his colleagues. And then he says, all right, I'm going to take all of these variables, and I'm going to kind of throw them all in and do some analysis, and I'm going to come up with a degree of severity score that I can calculate based on what I can measure on a graphics tablet. And so he was then able to validate that and say, I can predict the severity of these spirals as they were rated by a movement specialist just by plugging them into this mathematical formula. So he can kind of come up with an overall degree of severity score for a spiral regardless of the disease that the spiral is affected by. So, okay, who cares? So we can see that this severity score might have some sensitivity that goes beyond our neurologic exam. So if you have Parkinson's patients who are early in their disease, they're unilaterally affected by their Parkinson's, you can expect the affected side is going to have a different severity score than controls, right? They're bradykinetic, they're tremulous on their right arm spirals are going to be different. But if you have patients in whom a neurologist can't recognize Parkinsonism on the non-dominant side, if you have them draw spirals, their spiral scores are still different than that of controls. So he's demonstrating that he's identifying some abnormalities in their motor functioning before the neurologist can just in examining that patients. So does this degree of severity score give us maybe an earlier look into kind of the motor dysfunction in Parkinson's patients? So what else can we learn about Parkinson's? So one thing that Seth looks at is the downward pressure of the spiral. So how much pressure is exerted as the patient's writing the spiral itself? And in Parkinson's, we know that the affected side, they're going to exert less pressure downward on the page. So again, we go back to these right side predominant Parkinson's patients, they're going to have less downward pressure with right-handed spirals. The other interesting thing that he found is if you break those spirals in half and look at one hemispiral and another hemispiral, there's also differences in left side versus right side. But that holds true, and that correlates with the side that the patient is affected on. So you have a right side bradykinetic patient. They draw a spiral with their right hand. That right half of the spiral has less pressure. They draw a spiral with the left hand, the one that's less affected, but the right half of the spiral still has less pressure. So what he kind of said is maybe this is kind of analogous to a hemianopia. It doesn't matter which eye you're using. There's still kind of this cortical representation of the visual field that gives us kind of a visual field deficit. So in this case, it doesn't matter which hand you're using. There's kind of this motor mapping or this motor space that says the right half of this motor task is more affected than the left half, even though they may just have right side predominant Parkinson's. So it goes beyond just kind of the normal decussation pathways we think of that say, left basal ganglia, right side Parkinsonism. Maybe there are some of those corticostriatal projections that kind of gives us some bilateral involvement, but it still adheres to that asymmetry, even if you're drawing with the unaffected or less affected side. So again, from Alon Lewis's group, Alon Lewis has postulated that essential tremor is a cerebellar disorder. He's looked at post-mortem studies looking at Purkinje abnormalities in essential tremor. And he says, well, maybe we can use this spiral drawing to kind of say, find some hallmarks of cerebellar dysfunction in ET. And so here on the left, this is a cerebellar ataxic spiral. And we've talked about width variability. So we're looking at the variance between all these loops of the spiral. You can see there's a fairly wide variance between these loops as we go through different successive iterations of that loop. Here's our ET spiral. Here's our axis that we use to identify our ET spiral. And you can see that similar wide variance. And so what Alon has postulated is that the width variability is a marker of cerebellar dysfunction. And if we look at other spirals, we don't see that width variability in normal spirals. And this is a normal, but if we do it in Parkinson's patients, we don't see that width variability. So maybe that is another physiologic clue that width variability is an indicator of cerebellar pathology in essential tremor patients. Back to our functional tremor patients. So here's our control spiral, here's our dystonic spiral, here's our functional tremor patients. And what they found, if you give them enough spirals, the variability in the tightness of the spiral was more abnormal in the functional tremor patients than in the controls or even in the dystonic patients. And the dystonia tremors, the dystonic tremor is a good control. And the dystonic tremor tends to be pretty irregular and unpredictable, just like you might predict with a functional patient as well. But the tightness between all the dystonic spirals tends to be pretty consistent, while with the functional tremor, it's wider here, tighter here, tends to be all over the place. So maybe there's some physiologic, some motor physiology markers we could do with digitized spirals to identify functional tremor as well. So kind of in wrapping up, one thing that I've kind of been hinting at or touching on a little bit was what do we do with dystonic spirals? So this is some of the work that I did in fellowship and I'm wrapping up now is we took a cohort of genetic generalized dystonia patients that were affected in at least one arm. We had them draw spirals and we matched them to controls. And as you would expect, the severity score was higher. So these are patients with a movement disorder. They're drawing a spiral. We expect that spiral to be more severely affected than a normal control. But what we also are trying to figure out is, are there some indices that tell us a little bit about dystonia physiology? And indices that look at the unpredictability of a spiral tend to also differentiate dystonic patients from controls with the greatest degree. And some of the indices that Seth uses are kind of, he'll do one index and then kind of take the derivative of that so that if it's changing in an unpredictable manner, that index is also going to be high when you start looking at kind of second order indices. And it's really those second order indices, kind of to use a cardiology analogy, the irregularly irregular spirals are the ones that tend to be the most dystonic. They're kind of unpredictable. They're not like an ET spiral where they fit a nice pattern or a Parkinson spiral where they fit a nice pattern. So now that we have some of these spiral irregularity indices, well, does it tell us anything about the clinical severity of the disease? And so here, this is the Burke-von-Marsden score for the affected arm. So kind of calculate a dystonia rating scale for the affected arm for all of our cohort, and then let's see if that correlates with one of these spiral irregularity indices. And we found that there's pretty decent correlation. So maybe there's some way we can use some of these spiral indices to monitor the physiology or the disease severity. Maybe you can say, well, maybe you can do that after DBS or after Botox or after treatment to kind of say, you know, well, we can use this spiral irregularity score to kind of as a marker that there has been some clinical improvement in the severity of this patient's dystonia. So just to kind of wrap up, we talked about kind of the ubiquity of spirals in disease rating scales. We talked a little bit about how to watch the patient draw handwritten spirals, but in addition to that, how to look at the product itself and kind of gather information from that about making differential diagnoses, refining differential diagnoses. And then we also talked about some of the data that digital spirals have given us. So we know that Parkinson's patients have severity abnormalities before they can be recognized by their neurologist. We know that some of the pressure differences in Parkinson's disease. We've talked about the axis in essential tremor. We've talked about the width variability, where maybe there's some indicators of cerebellar pathology in essential tremor that spirals have taught us. And then again, kind of variability in tightness in functional patients, variability in axis or in frequency when you're watching them right at the bedside. And kind of dystonia, kind of, we're still working on that, but maybe dystonic spirals kind of just have this irregularly irregular pattern that we need to kind of further drill down into. So with that, some acknowledgements for folks that I've worked with and have given me some assistance on this, and I'll open it up for questions you guys might have.
I'm not sure how much genuine benefit there is, but they used to say weighted eating utensils may facilitate for Parkinson's or even essential tremor patients eating. Is like if you had a 3-pound pen, would that blunt tremor or does it really affect it? Or really don't?
I don't know if anyone's looked, but I wouldn't be surprised if it did. And I think the analogy to that is kind of the bracing the hand on the desk. And so if you're introducing a little bit more inertia to moving an implement or a pen around, either with friction on the desk or with something that's weighted, that can knock down the tremor a little bit. Probably with ET, I don't know if anyone's looked at this. I know with my Parkinson's patients, ones who have resting tremor, but sometimes it comes out if they're holding briefcase or a purse, it almost seems like the heavier the object, they feel like that amplifies their tremor a little bit. So I don't know if a resting tremor responds less to kind of weighted interventions, but certainly with ET, and I don't know about dystonia, but kind of increasing the inertia that they have to overcome to perform the task, I think does have some dampening effect on the tremor. Yeah.
I guess I have a question about the dystonia and cerebellar. So if there's a cerebellar tremor, then that's straightforward enough. But in certain of the examples that you showed, it seems as if there was, that is in terms of the variability from move to move, that sort of thing, that there was a lot of overlap between them. I just wondered, you know, if you could comment further on that. And when you compare or try to distinguish the two, what do you find?
So Yeah, I mean, in terms of distinguishing, if we use the spirals to kind of distinguish a cerebellar tremor or just an ataxic spiral drawing from an essential tremor, you're going to see the loop with variability. You're probably not going to see that axis deviation in the cerebellar
So I was
disorder.
thinking dystonia though.
In the dystonia, so one of the interesting things, if we look, this is a slide I don't have. So in our dystonia patients, in addition to some of these smoothness and irregularities, we did find that this spiral width variability was also pretty abnormal in the dystonic patients versus the controls. And so some people have said maybe there is some cerebellar pathology in dystonia as well. So again, are we localizing that width variability in dystonia to the cerebellum? Or is the spiral width variability, maybe it goes beyond the cerebellum, maybe it's more of just looking at, there's something about basal ganglia disorders as well. I mean, our understanding of dystonia physiology is so rudimentary compared to kind of the other hyperkinetic movement disorders in terms of where do we localize it, what's going on, that I think it's increasingly difficult to kind of pin down what are the physiologic underpinnings when we look at kind of these motor tasks.
And again, if you stay with the cerebellar versus essential tremor, so I guess the variability is greater in cerebellar tremor. But what about the presence of access and amplitude, frequencies? Do you find any distinguishing factors?
In the cerebellar tremors, you don't really tend to see as much of that axis, where there's kind of a clear sort of delineated, in this direction, the amplitude of the tremor is maximized, as we would see in classic. I think the chaos of the cerebellar tremor kind of wipes that out a little bit. Yeah.
Does the speed of completing the spiral would be able to be a tool for detecting bradykinesia?
Yeah, so that's something Seth has looked at in terms of looking at the speed and literally the pen velocity. So he can calculate, what's the velocity of the pen. Normal people tend to accelerate as they go around the spiral. That makes sense because essentially what they're doing is they're probably completing each loop in the same amount of time, but because the loops are getting bigger, they're covering more ground in that same amount of time. So literally the pen accelerates throughout the course of the spiral. Parkinson's patients tend to be kind of capped. They kind of start going and then they kind of maintain the same velocity and they don't see that linear or that constant acceleration. Now, how much of that is the tightness? So if they're not making the loops bigger, then you could argue they're not going to move the pen faster because they're just covering the same circumference over and over again. But yeah, Seth has looked at some of the pen speed and said there's kind of a speed limit on Parkinson's spirals as opposed to controls. Yeah.
Once all this data is digitized or objective, you could use the spiral values to monitor response treatment.
Potentially, and I don't think anyone's done that yet, but if we can say, well, this index correlates with what we've typically used for clinical severity, whether it's UPDRS or dystonia rating scales or all those different tremor rating scales, can we say, well, we put this ET patient on propranolol and the frequency or the amplitude of that tremor has reduced? Yeah, presumably you could do that. The other thing that the holdup and the problem with this technology, at least is from the data that I showed you guys, is you need to have this graphics tablet and you need to have kind of this mathematical sort of ability to calculate, all right, you have this raw data, now you have to translate it into the indices. That said, we should be in an era now, if we can translate this to an iPad. Sure, you're going to miss out maybe some of the pressure data, but just with a finger or a stylus on a digital, touch screen, we should still be able to calculate with reasonable resolution, speed and coordinates in real time. I don't know if Seth has started to look to that, but I do worry a little bit, kind of looking at some of this stuff, is using the graphics tablet is great, but is it starting to become a little bit outdated as we kind of move towards some more additional technologies to kind of capture these, and something that's probably more portable to give patients in their home. When I gave this talk at Jefferson, they also said, well, why can't you just use the accelerometer in the phone? Just hold your phone, draw a spiral in the air. We know that using the proximal muscles and the distal muscles are roughly equivalent, but I think as we showed with kind of altering the grip, you still can see some differences in spirals. I think we're still at the point where you're going to have to do something on a surface, but maybe we're just going to get to the point where we have the patient with some wearable device or something that collects this data.
So if you look at serial handwriting samples compared to serial spirals, do you think there's more stability in the handwriting, or they both deteriorate kind of along the same path, or it's hard to say?
You mean if you have them draw 10 spirals, is the last one?
I mean, if you have other writing exercises like just their signature, their writing, and then have them do the spiral, do they kind of evolve in parallel, or they have separate lives, or we just don't?
I don't know. People have used kind of digital analysis of different motor tasks. Seth has done spirals, some people have drawn circles, some people have looked at handwriting itself. And some people have postulated that spiral drawing and handwriting, language writing, are different enough tasks in that handwriting, because it's variable, you're not forming the same pattern over and over again, that because of that unpredictability from task to task, that there may be more deterioration sooner than with a spiral where it's a pretty overloaded motor task that is kind of the same whether you're having me do it or I'm having them do it. And so some people said maybe the writing's going to deteriorate further. When they've looked at dystonia patients, we always think about dystonia patients kind of mashing the pen down into the page, and you kind of pick the page up and feel it like a braille on the back or something like that. And they said, well, if we have them draw circles or spirals, we don't really see a lot of differences in pressure. And when I did, you'll notice here, the mean pressure in the study we did didn't really differentiate dystonia patients from controls either. Now we postulated maybe we kind of maxed out the pressure. The graphics tablet can only measure so many newtons of force. But some people have also said maybe the downward pressure is not the dystonia, but it's a stabilizing maneuver in those more refined motor tasks of writing letters as opposed to doing something like loops or circles where you don't have to stabilize the arm as much. And so what we kind of said was, here's this pressure frequency, so is the pressure oscillating or is it changing as they go through the task? That differentiated dystonia from control. So we still saw some of that irregularity in the vertical axis, but we didn't see it was just kind of a mashing down and stabilizing maneuver.
I guess it also, just thinking down the road a little bit, so you could at least picture some of the digitized spiral drawings as potentially of value during dystonia surgery. So that might be both replacement of the stimulators or the frequency or reduction.
Right, and the tough thing about dystonia surgery and DBS or dystonia is, again, this kind of goes back to we don't understand dystonia physiology as well as we would like to, is that there's a delay from surgery to therapeutic benefit. So as opposed to the ET patients or the Parkinson's patients who do DBS, and you turn them on and they're like, you get the program right in and they're like, I feel better. For the dystonic patients, it's 3, 5, 6 months later that you start to see the dystonia melt. So there's some plasticity or remapping. But yet, could we find something in real time in the OR that predates that clinical therapeutic benefit that we wait for and cross our fingers for when programming as an outpatient? Yeah, potentially.
I mean, and sort of flipping that around, the spiral will also seem to be used this way, but for fMRI, where you're looking for macroconnectivity and so it could be that we've done tasking.
I agree. We can do PET or other functional imaging to kind of say, again, try and figure out what we can about the physiology of dystonia. Yeah, potentially kind of crossover application. Yeah.
everyone please, Minnie, Aparna, or David, you could just share with the,